Good afternoon, everyone. I'd like to thank our chairman, Dr. Ibn Gould. I'm the only non-surgeon, I think, on the panel, so I'm guessing this is the least anticipated part of the presentations today. But I'm going to go over the medical treatment options. So I'm actually going to do, some introduction, definitions, how we treat them in medicine, and then the drugs we use. And I'm going to do that all in 10 minutes. So here we go. Okay, so it's a motility disorder of the stomach. And it's delayed gastric emptying without a mechanical obstruction. So usually we do this by EGD, but you can use upper GI with small bowel follow-through. Here's the typical symptoms we're all aware of: nausea, vomiting, early satiety, postprandial fullness, abdominal pain, and bloating. Our differential diagnosis: functional dyspepsia, and this is actually a big overlap between this and a functional bowel disease. And I think that you surgeons are a little bit lucky in that many times you're protected from this by us GI and medicine people, but many of these, be careful, these patients can be sent to you with functional bowel disease, and certainly I think a surgical option is not a good idea for these patients. So H. pylori, peptic ulcer disease, eating disorders, and I ask every patient that I see in clinic whether they have a history of an eating disorder, including cyclic vomiting syndrome, rumination. And there's a very interesting conundrum in the evaluation and diagnostic testing in this, is there's not a real good correlation between the patient's symptoms and their degree of delayed gastric emptying. So it brings up that whole issue of functional bowel disease. So the pathophysiology is very heterogeneous here. I've listed sort of the things that have been identified: fundic hypocontractility, antral hypomotility, pylorospasm, which I think a lot of the surgical type options have been looking at in coordination of your antrum, pylorus, and duodenum. Gastric dysrhythmias, autonomic neuropathy, which is becoming more and more common in general in medicine. And again, I'll bring this up numerous times, this sort of conundrum or mismatch of the degree of symptoms and the tests that we do. Here you can see some of the epidemiology: 10 million adults. This is a big group of patients. Olmsted County data, so that's Mayo Clinic, shows that it's about 4 times as common in women as in men. And when we see these patients on the medicine side, they're often in and out of the hospital, in and out of ERs. So if you look at quality of life, it equivalates to serious medical conditions, including severe depression. So here's the big 3 in causes: idiopathic, and in our part of the world, we see this post-viral syndrome where the classic is a Utah kid goes on their mission, which is a Mormon mission, to some third world country, and they get horrible food poisoning or similar type illness, and they get sent home after they've lost 20 pounds because they can't eat. Diabetes, which as you know is becoming much more prevalent, higher with type 1, where you get higher autonomic neuropathy. And then you guys are, I guess, the rest of the problem: vagotomy, bariatric surgery, and fundoplications, and the like. A lot of meds. We know we're going through an opiate epidemic in this country. A lot of medications with anticholinergic side effects. We used to see a lot of transplant patients with drug-induced gastroparesis when cyclosporin was used more. Just a warning: some of the new diabetic meds that I've listed here also can slow gastric emptying. Other systemic disorders, again, I listed scleroderma, Parkinson's, and again, we're seeing autonomic neuropathy in a number of different disorders and an increasing number of patients with POTS. I can say I always look for it, but I've yet to come up with a cause of mesenteric ischemia causing gastroparesis, but this would be one that's actually reversible. Our diagnostic testing, as you know, gastric emptying scan is the gold standard. There are guidelines with the exact way to do these from the Neuromotility Society. You get a 1, 2, and 4 hour report. Be careful on the ones. There are some smaller centers that'll run 1 and 2 hour tests and then extrapolate to 4 hours. Really, the 4 hour is by far the most important time period to look at. Some places will also run liquid emptying, which can be useful because liquid emptying can be preserved in certain situations like diabetes and can be useful in the management of those patients. There is a wireless capsule out now called the Smart Pill, which we have at our institution that is shown here. It measures pH, temperature, and pressure, and it's been correlated with decent sensitivity and specificity with gastric emptying scans, as you can see there, if it sticks in your stomach for 5 hours. And there's a breath test using 13 carbon labeled algae, believe it or not, that is FDA approved. So you may see that used as well. Okay, here's our treatment algorithms from the GI literature. Step 1, you have to do a gastric emptying. They have to have typical symptoms. You exclude iatrogenic disease, meaning medications and the like. We use dietary maneuvers initially, a low-fat, low-fiber diet, and then, of course, if they're diabetic, try to get their diabetes under control. Then it's a combination, drug-wise, of Prokinetics and Antiemetics, and we'll go through those in more detail. Nutritional support, enteral feeding tubes. That's kind of how I got into this business. And then step 5, the gastric electrical stimulation, pyloroplasty surgery. Those are for the next presenters. Again, on the right, table 1 there is from a review article, systemic review, that tried to look at the strength of the recommendation as well as the level of evidence. So you see, Prokinetics seem like they would be the perfect option, although there's not great drugs for that, as I'll show you, but strong recommendation and moderate evidence, and we'll go again through all these. So here's our algorithm. We start them on the, quote, gastroparesis diet, and there's ones online that we use and give to our patients, and then the typical agent we use is metoclopramide to start. I put exactly there the dosage, 5 to 10 milligrams before meals. Then you can use it if it works, use it at its lowest effective dose. But if you have side effects, which is common, Domeperidone, which is not FDA approved in this country, incomplete response, we use erythromycin, and then we keep going around in that cycle with sometimes enteral nutrition support. I put in this, table 5 there is a study looking at oral versus a new formulation of metoclopramide that's intranasal. And you can see there in terms of their mean change from baseline in terms of their number on their gastroparesis symptom index that you get better effect with intranasal. And that I think is basically a better form of delivery in a patient whose stomach doesn't empty well. The problem with metoclopramide, otherwise known as Reglan, is there's this FDA black box warning that it can cause tardive dyskinesia and shouldn't be used for more than 12 weeks. That tardive dyskinesia is not necessarily reversible, so that really shouldn't be using it for more than 12 continuous weeks. And I can tell you, I had a patient a couple years ago that had been on it for a couple years that came into my clinic shuffling like he had Parkinson's, and we took him off, and his family thought it was great because he stopped shuffling. So you got to be very, very careful with that, and taking him off, again, doesn't always reverse the tardive dyskinesia. It's still a rare complication, but it's hard to get around once you got an FDA black box warning. So here's the details about metoclopramide. You can give it IV, IM, sub-Q. Again, there's this intranasal spray. There's also liquid and an oral disintegrating tablet, ODT. The adverse effects you see there, in addition to tardive dyskinesia, are these motor neuromuscular effects to be on the watch out for. So how do you get around it? Drug holidays, use the lowest dose possible, and again, I showed you that data with the intranasal. Again, anything to promote absorption in patients with poor upper GI motility. Domeperidone, it's a D2 agonist, so it's a monoline agonist, very similar to Reglan, but doesn't cross the blood-brain barrier, which is great. So you don't get a lot of those CNS and sedation side effects. Both antiemetic and anti-nausea properties, just like metoclopramide. You can see the adverse effects there. I have had patients get galactorrhea. So again, what are the tips? We check the EKG, we check the potassium once a year. Again, never FDA approved in this country. This seems to be a very international conference. It's approved in much of the Western world and in Canada and Mexico. So our patients don't have too much trouble getting it. Erythromycin. Actually, erythromycin is a really powerful way to jumpstart your stomach IV in the hospital setting. I put the dose there. You can give it PO on liquid. Its main adverse events is tachyphylaxis, that you get tolerance after a few weeks. So again, drug holidays and liquid, so it's absorbed. So antiemetics, the standards, you can see there, phenothiazines, antihistamines, and the scopolamine patch. None of them really well tested in gastroparesis patients specifically, but we know they do work in patients with nausea. The novel ones, the 5-HT3 receptor antagonist, Zofran, ondansetron is a classic, and there's an oral disintegrating tablet from that. This granisetron, I'll show you a study on. There's also the 5-HT4 receptor agonist. There's an old drug that some of the older docs in the room will remember called cisapride, which is a great drug for this. There's neurokinin receptor antagonist. And then this is a field, especially when there's a lot of psychological and perhaps functional overlay, that perhaps complementary alternative medicine can be useful. And there is data for acupuncture and cognitive behavioral therapy. So this is, again, one of the new 5-HT3 receptor antagonists, granisetron. It's just a transdermal. And so this was in a study in gastroparesis patients, and it doesn't show up too well there, but on all these upper GI symptoms, nausea, vomiting, even abdominal pain, which you wouldn't think would get that much better, improved with this medication. Again, I think the key here is the delivery system. This is apripotent. It's a neurokinin receptor antagonist. That receptor is in your basal ganglia, associated with your vagus, motor, and sensory receptors. Very approved for chemotherapy and post-op. This was a very recent study in Gastro, which is our #1 journal, where the primary outcome, as you can see, wasn't any different, nausea improvement. When they looked at the total gastroparesis symptom index, though, it did have some benefit, and mostly on the severity of nausea, so some benefit. And we just started a study at our institution on a new neurokinin receptor antagonist as well, so there's a lot of interest in this area. This is to show you, this is Nortriptyline, which, as you know, is a tricyclic or tertiary amine, so less side effects than the traditional ones. This was in JAMA, so this was felt to be a pretty significant study in gastroparesis and has been somewhat indicative of this field in terms of pharmacology, that there's been a lot of drugs tried and a lot of drugs failed. So this is a multi-center, double-blind, randomized controlled study, decent size. They use dose escalation like we would do in real life, and you can see no benefit and more withdrew on the drug side than the placebo side due to the side effects of tricyclics, but nothing better, nausea, bloating, and total score, or their sense of fullness. What about nutrition? So here's what we do. Again, 4 to 5 small meals a day, 25 kcals, increasing liquid nutrients because, again, sometimes liquid emptying is preserved, and, of course, control their diabetes as well as you can. Start thinking about feeding tubes, obviously, after when they've lost a fair amount of weight, and be careful of the gastroparetic patient who is of normal weight or obese coming to you for a surgical option. Enteral is obviously preferred over parenteral when you can do it, as is post-pyloric. This is from one of our main GI Society guidelines going over the various feeding tubes. And G tubes are great for decompression, but they're too big for long-term use. We often use nasal jejunal tubes to at least make sure the patients can tolerate them before we're going to put a percutaneous tube. And then you can use a PEG-J, which both can decompress and deliver distally, or sometimes we'll use both, a decompressive PEG and a decompressive direct J. That way you get two more stable tubes in those patients. So future directions, again, I wanted to bring up this conundrum about this lack of direct correlation between their symptoms and their delay in gastric emptying, and that's what's caused a lot of the new drugs to be tested not to get approved. But there's a whole bunch of drugs, both Prokinetics and Antiemetics, in phase 3 testing along the lines of what I've gone over before in terms of Antiemetics and Prokinetics. And a problem with the present drugs now, as I've shown you, is a little bit with the cardiac side effects, especially in patients, if they're really bad, who are going to have electrolyte abnormalities. So thank you, and I hope I didn't go over.